Hello and welcome. My name's Elana Gordon. I'm a reporter and producer at The World covering global health. This is a Facebook Live Q&A about the coronavirus pandemic, reopening schools and workplaces, something that's on so many of our minds. With me is Joe Allen, Associate Professor of Exposure Assessment Science in the Department of Environmental Health at Harvard's T.H. Chan School of Public Health. Joe, thanks for joining.
Yeah, thanks for having me. Good to be back with you, Elana.
Yeah, and we have another guest to kick off the discussion. Kirsty Graham is CEO of Edelman Public Affairs and Chair of Edelman Health, and she'll be just presenting a summary of a new global survey about workplace trust and the coronavirus. Thank you, Kirsty.
Thank you, Elana.
You can post your questions for all of us on Facebook at Forum HSPH, or you can email them to the forum at hsph.harvard.edu. This Q&A is jointly presented by the Forum, Harvard's T.H. Chan School of Public Health, and The World from PRX and GBH. We are doing this through Zoom and Facebook. And again, as I mentioned, this Q&A is all about reopening schools and workplaces. It comes at a time when the US is reaching a pretty bleak milestone, 200,000 deaths. We're all bracing for the fall and winter months. Communities around the globe are also experiencing major challenges, navigating outbreaks of different scales and scopes, trying also to get back to work and to school. So Kirsty, first I wanted to start with you. Your report dug into global sentiment of returning to work during COVID-19 around the globe. That included a survey of more than 3,000 people in 7 countries, pretty varying from Singapore to South Korea to the UK to Germany to here in the United States. What did you find? What were some of the key findings? It seems like while there's a lot of variation, there's some universal or some themes that have come up.
So thanks very much, Elana, and thank you for having me here today. So yes, Edelman has been doing this research on trust in institutions for 20 years, looking at government and media, NGOs and business. But because of the coronavirus, we've actually done some very specific ones this year. And this one we set out during August to look at workplace trust in the time of coronavirus. The big takeaways are exactly as you just said then, Elana. First of all, people have huge concerns and believe that they will see a second wave. So second wave expectations are very high. 68% of people globally across those 7 markets that we surveyed see that as coming. The second thing that we learned was that people are still very scared and don't trust the idea of resuming to normal activities. And there was a real distinction between people, how they felt about an activity, whether they considered it safe, versus the likelihood that they would do that. So when we asked them about going to a doctor, visiting a hospital, buying groceries, getting on an airplane, doing leisure activities, there was a clear preference for only doing what was necessary. So the most essential things are the type of things people are doing, but there's a hesitancy when things become non-essential. Thirdly, when we asked people about how they felt about returning to office space and whether they thought their office space was trusted, only 51% globally said they felt that the workplace, that they could trust that environment. When we asked how likely it would be that they would go back to that office place in the next 3 months, it was even lower. Globally, it was 31%. And interestingly, in the US, that delta was greater, with 50% believing the workplace was they could trust it to be safe, but only 20% saying that they would likely return to the office in the next 3 months. When we asked about the type of precautions that employees needed to see to feel protected, very interesting finding here. They expect to see at least 4 precautions from the employer about going back to the office. So this is things like mandatory wearing of masks, social distancing, limiting the number of people in office, taking people's temperature. But the clear takeaway is it's not just one thing, it has to be a combination of at least 4 types of precautions. We broke that down in the US, and what was really interesting is there is a degree of politicization in some of those workplace precautions. There was actually a 20-point gap on the question around the wearing of masks between Republicans and Democrats. When we asked people about how they felt about their remote work environment, again, a very interesting finding. 73% felt that they had the option to work remotely for the foreseeable future. So they felt comfortable that they would be able to have that option. 74% also believed it was not hurting their career to be working remotely. The next part of the survey, I'll just touch on, was really an interesting piece around where people are getting their information on the virus. And the one conclusion we had here is there's no clear source. So it's a combination of major news organizations, government, and social media. And yet where people trust their information is also quite different. People have low trust in the social media space, and they're far more likely to trust something that's come from an expert source, be it a scientific advisor or a doctor. The last thing I would just say is really we probed on vaccine receptivity, because one of the things that we took away from the survey is there are a lot of disconnects, people being concerned about a second wave, but being vaccine hesitant, thinking about returning to work, but not necessarily prepared to wear a mask, going to places for information, but not necessarily the sources where they trusted the most. So the last thing I would say on vaccine receptivity was it's very mixed. And in terms of people saying they would not take a vaccine or be unsure about taking a vaccine, 36% globally are in that category. And it's far higher hesitancy among women for lower income, and in the US, particularly for people of color and for those who identify, there's a bit of a delta also on political affiliation. Overall conclusions?
Yeah.
Overall conclusions, I would just say there's a stay put mindset going on here. People are staying at home. For employers, there's a real question about return and trust for the workplace. And people want multiple safety precautions, and they want consistent communication.
Just to wrap up with that, are there any particular conclusions or constructive conclusions on how to respond to that you're seeing in workplaces, or how that relates to local governments?
So I think one of the things that is very interesting in this is that trust is localized. I think the role of the employer now is incredibly important in building trust, in showing flexibility, and thinking and partnering with local government around things like commuting, showing flexibility around the length of the workday or the hours of the workday, particularly for those who may not have childcare. There is a real need to be in communication with employees and to draw on expert communications. But the takeaway is it's about what's happening in my environment and what's happening with the virus around me.
Great. Kirsty, thank you so much. From there, I wanted to, it's also grounding to think about the ways in which around the globe there is a lot of confusion, mixed messaging, hesitancy, all sorts of things. And so thank you for sharing those findings. Joe, I want to turn to you now and maybe segue into, here we are, we're taking questions. Please post your questions. This is a Facebook Live. Joe Allen, you have quite a bit of expertise on transmission and making buildings safe as we go indoors. And so there's been a lot of mixed messaging, especially lately. Some confusion over the weekend about some guidance posted by the Centers for Disease Control that was then removed about aerosol transmission. Can you describe what happened and clarify, help us understand all of this?
Yeah, so nice to be back with you. And look, trust is low for these kind of reasons. CDC yet again released guidance and then retracted it. And now the public is even more confused yet again. This just happened 2 weeks ago with testing of asymptomatic people or not. And so let me explain what just happened over the weekend for anybody who hasn't quite been following it. But really what happened on Friday, CDC for the first time acknowledged that airborne transmission was happening. Not only did they say it was happening, they said this is the main way the virus spreads. That's a landmark shift because people in my field, myself included, since early February, we spoke about it, I think in April or May, have known that airborne transmission is happening. We've been yelling from the rooftops, writing op-eds, doing interviews, writing peer-reviewed literature, editorials, trying to alert the world. In early July, 239 of us signed a letter to the WHO urging them to recognize the evidence, and it is airtight, that airborne transmission is happening. So we started to have a shift. And just a couple of weeks ago, Dr. Fauci was at the Harvard School of Public Health. Dean Michelle Williams gave me the opportunity to ask him a question. I asked about airborne transmission, and he said they were looking into it. Well, it was only 2 weeks ago that Fauci returned to do grand rounds at Harvard Medical School. And he said, bottom line, there is much more aerosol transmission than we thought. So we were turning the corner. CDC Friday announces big change on their website. All of a sudden, though, yesterday morning, they retract that. They pulled it off their website. We've gotten all sorts of conflicting information since that time that says, well, it didn't go through the right approval processes. Updated guidance to be available yesterday afternoon, never came. So again, it's just more confusion. The public got this big message. Airborne transmission is happening. The Faucis of the world, they're starting to say it. We've all been saying it, and then it gets pulled back. And already on the radio this morning, driving my son to school, I heard that on the radio. Oh, turns out the news we shared yesterday about airborne transmission, the CDC has walked that back. The public doesn't know what to believe anymore. What they should believe is that airborne transmission is happening. And let me tell you what that means from a practical standpoint. It just means you have to add one more control to what you're doing already. Hand washing, masking, distancing. Just make sure you're also thinking about ventilation and filtration indoors to address this far field or longer range transmission that can happen.
So can you clarify then, I see aerosol transmission, droplets, without getting too granular, but sometimes I'm trying to differentiate between what is a debate over language and understanding versus what's actually changed in how we prevent coronavirus from spreading. When we think about what airborne transmission means versus what aerosol or whether something's infectious, the particles may be in the air, but whether they're infectious and for how long, it does get very confusing. And I think what we're all looking for is like, okay, what are the ways that without overreacting, but as we move indoors, as workplaces reopen, like how do you understand it? And I understand it's a changing virus. It's new. We're learning stuff every day.
Yes, that's a really good question. And so there's nothing to be scared about with the word airborne. I know it can induce an anxiety, but it really just means you do the addition those controls. Mask wearing is key. And think about opening up your windows a bit more, better filtration. But let me demystify this and then talk about the semantics. Let me demystify this a bit, right? So when I breathe or talk or sing or cough, anybody, right, we emit a range of particles, very large particles. And if you're interested in the size, 100 micron will settle out quickly within 6 feet. But you emit a continuum of particles. And in fact, the large particles evaporate really quickly. And so they turn into smaller particles, what we call droplet nuclei. Well, these smaller particles in the 1 to 10 micron range, which is where most of the virus is in these respiratory droplets, well, they can stay aloft for 30 minutes or hours indoors, and they can travel well beyond 6 feet. So we know this. This is basic aerosol physics. And this is why we're starting to see air sampling that has shown viable virus detected at 16 feet from a patient in a hospital. So the air sampling matches with the basic physics. We've seen major outbreaks with time spent indoors where these smaller particles that can float will build up over time if you don't have ventilation. Now, distance still matters, right? You can imagine, smoking is one way to think about it. If I was smoking, you and I were talking at 3 feet, well, you're going to get a blast of the smoke. At 6 feet, a little less. If you're at the back of the room, you'll smell it, but it won't be as intense. And if that room is well ventilated with a cross breeze, you may not even know I'm smoking, right? So all those factors, you can think about it like smoke in that way. Here's where the confusion comes in with droplet and aerosol. It turns out that a lot of the medical community has thought that 5 micron particle is a droplet that will settle out within 6 feet. This goes back a long time, decades. And the reality is we know that these particles travel beyond that 6 feet. And this was what Fauci, to his credit, said at Harvard Medical School. He said, we've had it wrong on the droplet aerosol side. Turns out he was convinced, the aerosol physicist, we convinced him that these particles can travel. So the take home for everybody is just that when people talk, sing, just breathe, you emit a continuum of particles that can travel beyond 6 feet. Distance still matters. Masking is critical because it still blocks the emissions and acts as some level of filtration for the other person. And if you dilute or clean the air, you can further reduce those airborne particle concentrations.
So how is that informing now? Let's get to some of the real world implications and what's happening right now. How have schools been doing with this? And then we can move to workplaces as well. But just as now we are seeing schools back in session, at least in the United States.
Yeah, so my team has been working quite hard on this. Going back to May, we released a 60-page report on risk reduction strategies for reopening schools, holistic risk reduction. But in the context of airborne transmission, we had a section in that report around healthy buildings and the strategies schools can take, including opening up the windows, or if you have a ventilation system, bringing in more outdoor air. And in the absence of being able to do that, or if your systems are not up to speed, you can use a thing like a portable air cleaner with a HEPA filter that will give you several air changes per hour of clean air, 4, 5, or 6 air changes per hour. An air change per hour is easy to conceptualize. You could think of it this way. At 6 air changes per hour, every 10 minutes, the full volume of the room is cleaned. Now, for reference, a typical home in the US has half an air change per hour. So it takes 2 hours to clean out that air or dilute that air. So my team has put out a lot of guidance here. We recognize it can be confusing for schools if it's the first time you've really thought hard about this from an infection control standpoint. We have guides on how to measure ventilation rates, guides and tools for how to select the right size portable air cleaner for your classroom. We've been out at schools measuring ventilation rates. We put together all these tips for how to do it. A couple op-eds on how opening windows can give you 3 or 4 or 5 air changes per hour. So really some simple strategies that you can take in schools, even resource constrained and time constrained. And I'm really quite happy with what I've seen. You know, I presented to the Cambridge Public Schools up here, right around Boston, and the mayor of Cambridge was on the call too. And they were recounting the steps they've used. They've used our tools, it turns out, and actually started to test ventilation rates in the schools. They bought portable air cleaners with HEPA filters. So they're really taking it quite seriously. The guidance and tools are out there. These are low cost, easy to implement strategies that can really reduce risk.
So one question, this comes from online, from Lola in Vermont. How much weight should schools be giving to adequate ventilation in the debate around in-person instruction? Is there a basic standard? I mean, because you've thrown out you have to measure each building and classroom situation.
Yeah, so that's a really great question. And I actually like to take a step back because I sometimes think we get reductionist in thinking about exposure and risk just in the classroom and just on airborne. So let's take a big step back and recognize that there are devastating consequences to keeping kids out of school. We have virtual dropouts. Millions of kids rely on school for food, socialization, learning. UNICEF reports that kids who are out of school are more likely to suffer abuse, neglect, exploitation, and violence. So there are massive risks we have to put into this exposure and risk calculus. Then we can think about what we need to do in the classroom, and we have a range of strategies, right? And really 2 conditions precedent before reopening. One is, do you have low community spread? If you do, then that decreases the likelihood that any one person brings it into the school. Second, it can't be schools as usual. Then you put in these other control strategies, of which ventilation is one, including trying to de-densify. Universal masking is absolutely critical. In fact, if you look at all the risk models, the ones my team has built, other professors have built, these engineering controls like ventilation filtration work. They're really good. The intervention that drives risk down the most, universal masking. So in exposure and risk, we take a step back, wider lens. It's an absolute national emergency when we have all of these kids learning from home, and we need to do what we can to get them back. And the strategies to do it are actually quite straightforward, and we know they work. They're proven risk reduction strategies.
This is a follow-up from Mariska. What exactly does low community transmission mean? Like how low is low enough?
Yeah, really good question. And so I joined and partnered up with a couple of their faculty at Harvard, including Danielle Allen at Harvard's Safra Center for Ethics, Ashish Jha before he went to Brown University at the Harvard Global Health Institute, a couple other epidemiologists, Helen Jenkins from Boston University, to produce a report on the when to open. So exactly this question, what metrics should you be tracking to determine if you are in a green, yellow, orange, or red zone? I'll give you a resource. All of the guidance we put together for schools is at schools.forhealth.org, and we can share that with everybody. For Health is forhealth.org. That's the home of my Harvard Healthy Buildings program. There are tools on there to pick the portable air cleaner, this link to when to open strategies, 20 questions every parent should be asking before they send their kids back to school. So there's a lot of good resources on there for you, including some of the hard science, not just the simplified tools. But that's where you can find that guidance that looks at the number of cases per 100,000 people in your area. So first condition, low community spread. Second, can't be schools as usual. You have to implement the risk reduction control strategies.
So as you're saying all this, I'm thinking about also, in communities where, from a broader, are there the biggest like systemic as understanding as workplaces reopen, as schools reopen, like kind of the systemic policies or broader things besides the building itself? I mean, it sounds like masking is the main thing, but what are like some ways to kind of protections, because there are people that are working now and always and are in circumstances or in closed spaces or whatnot. And so like, what are the big takeaways that you think of in terms of keeping infections low or reducing infections as much as possible, given what you know about buildings as they are new and old?
Yeah, really good question. And a lot of what we've seen, we can keep people safe indoors. And if we put in the right protections. Look what's happening in healthcare environment since March. Really done a much better job, really good job of protecting healthcare workers. They can't distance. It's a high risk environment where a lot of people are in there shedding a lot of virus. But what have they done? It's hand washing, it's universal masking. And this one you have to pull out a little bit and remind, they also do a really good job with their buildings. They pay attention to filtration and ventilation. It's really a time for the basics. I keep repeating myself, but hand washing is boring, but it works. Ventilation and filtration, it's kind of boring, but you know what? It works and it's really important. We've also seen many other examples where kids have been in childcare or camps or even schools that have had to stay open. I've worked with a community center, a community childcare center. They've had to stay open and they've kept control of the cases. So there are a lot of these positive examples out there where we can control this spread. But what happens is, of course, is that if we have a case, and rightfully so, it makes the news. And I think it gives this impression that maybe everything is this super high risk environment. When really, if you look at where the cases are happening and dig down into the conditions that led to the cases, it is inevitably high community spread, no masking, overcrowding, and no to low ventilation. That's in camps, that's in schools, that's on a bus. That's in offices. That's the Biogen outbreak. Every one of these, we see that, and it's really quite consistent. It's less about the place, it's more about what controls are in place or sometimes not in place.
This question is from Katie. It's a little bit tangential, but one of the ramifications for reopening is the implications for extended families, like grandparents, and their ability to have physical contact with families. There's a lot of impacts on social isolation. So what's your assessment of risks and what do you recommend for families that are facing these decisions?
Yeah, this is really quite important, as we all know, the isolation, the loneliness, we all need that social connection. And yeah, it's really quite important as we open up schools that we recognize that as our kids have a wider social network, we have to be even more careful when they're in and around people who are at higher risk. And this means taking those similar precautions I've been talking about for office and schools into your home. If you have people over, or if people are essential workers, they're out and about, it's opening up the windows. It's being really diligent with hand washing, portable air cleaner with a HEPA filter in the room where you're spending your time. I mean, this is the way we can lower the risk. Importantly, though, when we think about kids, there's a couple breaks this virus has given us. It hasn't given us many, but in terms of kids, a couple really important things. One is they're less likely to get it than adults. And so remember, it's a conditional probability. If community spread is low, you have lower cases and they're less likely to get it. That's a good thing. Two, if they do get it, they're less likely to die. The infection fatality rate is on the order of 3 in 100,000 based on the largest seroprevalence study I've seen, over 350,000 kids 0 to 19 years old. That's on the order of 10 to the minus 5 risk, close to 1 in 100,000. So that is a good thing. We were spared in that way. Third, it looks like, on balance, and on my read of the whole totality of the literature, that kids are less likely to transmit. And there's a couple reasons why. People have talked about they generate fewer breath droplets. So we have some benefit there. It doesn't mean kids can't get it. They certainly can. It doesn't mean kids can't transmit it. They certainly can. It looks like it's less likely. It also doesn't mean we stop doing our controls, right? So particularly people who are older and at the highest risk, where the risk is percent level if you get it. Percent level risk of death, then you have to put in these additional controls, in particular as your family's social network widens because of school reopening.
I mean, do you imagine that most schools will wind up not staying open for a long time, or what happens when a case comes up? And also there are tensions, we've seen in Massachusetts, like between the teachers unions and kind of the local jurisdictions about how to protect teachers and how to protect the students too in these situations.
I haven't slept since May thinking about this question and this idea that maybe kids will be out of school for a year or more. These consequences, we're seeing the cases as consequences, right? You can predict the public health headlines that are coming in the next couple months and years related to kids being out of school. There's a missing part of this conversation, and it's the kids who are missing, right? You'll hear, so I'll keep my kids home. Yeah, I bet you have Wi-Fi, computers, right? Maybe you can afford a tutor. You've seen pictures of kids in a Taco Bell parking lot using the Wi-Fi. Tens of millions of kids without high-speed internet. And so we're seeing these major costs to keeping kids out of school. I want to be clear, though, that the strategies we've written for how to keep people safe in schools are for both kids and adults. So we can do this safely. If we follow these protocols and put them in place, we know we can keep people safe indoors. And it's absolutely critical we do it. And I'm quite frustrated with places that have not opened when there's low community spread, their buildings are ready, and we've now squandered a month of really nice weather, at least here in the Northeast, where these are times you could be outside on the ball field having class or opening up all of your windows because it's quite cool. So we've lost some time for these schools that haven't opened. And so it's just even more important now as we come into the winter that they put in these additional controls. Otherwise, you can see if cases start going up, people say, well, keep schools closed. And now we're facing that honest nightmare scenario, kids out of school for a year. It is a national crisis. I don't see the urgency. I haven't seen it since March when we took kids out of school. It's deeply, deeply concerning and should be treated like the crisis it is. And we should be not opening other sectors of the economy while kids are out of school. This is our most urgent and pressing problem the country faces right now.
To what degree do older schools, just infrastructure-wise, face more of an uphill challenges when it comes to these things? And there was another question that come in, so I want to kind of tie these two together, having to do with okay, so you do get more filtration systems or purifiers. Is there a certain kind of training then that's needed, or how do you actually, are there ways that this could maybe fall short, or how important is it, how intuitive is it for all of this sort of thing? Yeah. So those are two questions.
Yeah. Well, and they're good and they're related. I think people think, well, these old buildings, they don't work. We have old systems. We have underinvested in school infrastructure for decades by a lot. And I'll tell you, the typical school building is at half the minimum required ventilation rates, right? So that's our baseline here. We have just underinvested as a country in our school building. And I can tell you why I think that is, but let's answer the other question. I've done forensic investigations of sick buildings for over a decade. There wasn't an old building, an old school, an old office that was a problem that we couldn't turn into a healthy building with just a little bit of attention. That's a key message. It doesn't have to be complicated. There's always something you can do. It can be an old building, a new building, and you can address these problems. If you look at the solutions we're putting forward, or the recommendations, you'll see I'm very careful not to make recommendations for some fancy new technology that's going to take 4 months to implement, going to cost every school $1 million. We can't do that. So the solutions we're talking about are really tried and true, based on the science, that are easy to implement to the question. A portable air cleaner with a HEPA filter, you size that right for the room, you plug that in. It's plug and play, really. Upgrading your recirculated air filters from a MERV 8, MERV, a MERV 8 to a MERV 13. Bringing in more outdoor air. So you might have a unit ventilator in your school. Well, the damper might be set for 20% outdoor air. Can you get it to 40%, 60%, 80% when the weather's nice? So there's always some tips and tricks you can do. And what we've done is we've set a target for schools. Target 4 air changes per hour is the minimum, 5 is excellent, and 6 is ideal.
What do you mean by air changes again? And that actually comes up with a question of how many air exchanges per hour is ideal.
Yeah, so again, air exchange rate is how much volume of the air is exchanged with outdoor air. So again, your home has about half an air change per hour. If you're in a tight, newly constructed home, energy efficient, you might only get 0.1 air changes per hour. It means it takes 10 hours to replace all that air. We've set so a school, the minimum target, minimum ventilation standards is about 3 air changes per hour. That's not enough. That's a minimum target not set for infectious disease transmission like we're experiencing now. So we say 4 minimum, 5 is excellent, 6 is ideal. And if you think about that again, 5 air changes per hour means every 12 minutes, the full volume of air is cleaned. If it's running through a HEPA filter, which is near 100% filter efficiency, you're capturing everything that goes through there. And so if that sounds complicated, I want to tell you we have a really simple spreadsheet tool on our website you can go to. You plug in the dimensions of your classroom. It'll walk through the steps and even point you for what you should be looking for in terms of if you're going to make that purchase to say, well, how do I get to air change? And remember, they're all additive. Your window opening might give you 2 or 3 air changes per hour. Your portable air cleaner might give you 2 or 3 more. Those add up. Recirculated air through a better filter gives you additional air changes per hour. So you can quickly get to higher air change per hour, relatively quick, easy. Where we set that standard, it's really a big shortcoming. CDC never put out a standard. ASHRAE, the standard setting body for ventilation, did not put out a number, but you start talking to schools and they say, what number should we target? So we worked with some other professors, Shelley Miller at Colorado University Boulder, to set some of these targets for school that we think are evidence-based. And last thing, masks are most important. All these engineering controls are good, but masks will drive down this risk even more sharply than these air changes per hour.
So I think this time has gone by super fast, but I wanted to put in one more question and then give you a chance to kind of wrap up and clarify, again, given all of this kind of confusion in messaging, not necessarily like what are the implications of how we should go about thinking about workplaces and schools in terms of preventing transmission. But first, just a quick question from David, how do you judge an apartment building or office building, like elevator spaces and stairwells that are reasonably safe versus ones you should just totally avoid? How do you assess that? And masks, gloves, that sort of thing.
Yeah, so that's a really good question. And this is where organizations, schools included, need to do a really good job of communicating what they're doing, because you will walk into a place and you will see whether or not everyone's wearing a mask. If they're not wearing a mask, I'd leave. You will see they'll be doing cleaning. There'll be signage on where to stand. People maintaining their distance. Those are all visible. You won't be able to see the invisible controls like ventilation and filtration. You really won't. It's a good sign if you see all the other things happening. It means they're paying attention to the guidance, but you can also ask them. I'd also trust your senses. It looks like too many people, when we describe underventilated spaces as saying, it feels kind of stale in here or stuffy, or it smells in here, you can sense that. And you smell people, we smell bioeffluent. In fact, the ventilation standards are set to control odors largely, right? So you don't walk into a space and think, ooh, too many people in here, it doesn't quite smell right. So that's really what's happening. So trust your senses there and ask these hard questions. Parents should ask these questions of their schools. Employees should ask these questions of their employer and make sure these strategies are put in place. So that's really the only way you can assess it. But the big picture here is that we're having a lot of success, to your last point there about what to do. And I think of the timeline of strategies, right? We have this vaccine as this end game somewhere off in the distance. And we can talk, there's other sessions to talk about that. Before that, or right around the time, we have some new therapeutics that are coming on the market. Maybe before that, we have these rapid antigen tests coming up, these 15-minute home pregnancy tests that my colleague, Professor Michael Minna, has been talking a lot about. But the right now strategy are the non-pharmaceutical interventions. It's everything you've heard and we all know well at this point. Masking, distancing, hand washing, and now just add 2 others to your strategy. Think about ventilation and filtration. So really open up those windows, dilute the air, or make sure your filters are upgraded. And really, we're having a lot of success with those non-pharmaceutical interventions before these other strategies can come online and onto the market that are really about our end game.
I think that's a good place to end this conversation, although I have so many more questions and I'm sure that viewers do too. But we're going to wrap up here. Thank you, Joe, so much for joining us and fielding everyone's questions. and also to Kirsty Graham earlier for joining us from Edelman Health to discuss kind of how trust is feeding into workplaces and schools right now. So this Q&A has been jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and the World from PRX and GBH. You can view this full discussion on our Facebook pages and send feedback at Forum HSPH and at PRI The World. Thanks for joining us.
Thanks, Elana.